So there are some people beside me and they are asking to join, but their network is bad.
So what do you do about them now?
I don't know, maybe they
Hmm?
and they'll listen to the lectures with me on my phone.
No
They are new
problem.
in
Now,
this.
just so far you are sure that they attended the lecture.
Yes, sir.
I've been able to join.
Okay, some of them are entering now. If we should try again, try again.
I've been able to join. Party Alati.
Some people are joining, yes, sir.
Try.
Mute
Try,
your mic.
they'll try again, sir.
Mute your mic. Everybody mute your mic. Good afternoon. Good afternoon. You're welcome to, if you can hear me, raise your hand. Good afternoon. Or you can just type yes, sir, if you can hear me. Type yes, sir, if you can hear me. Okay, thank you. All right. You are welcome to today's lecture. We are still on the course Action and Uses of Medicines, AUM 221. So the topic for today is factors modifying the dose and effects of drugs. Factors modifying the dose and effects of drugs. Mute your mic. Mute your mic, please. All right. So basically, this topic talks about why people react to drugs differently. Why people react to drugs differently. And at the same time, why the same person can react to a drug differently in different situations. So that's what this topic is trying to let us know. So in terms of how the factors that modify, that will make you to say, okay, let's change the dose, or the factors that cause a particular effect of drug on an individual or between two different individuals. So, as I said before now, people actually react differently to the same dose of a drug. The same dose, oh, but the way A will react will be different from the way B will react. And as I said before now, even the same person may even show different responses at different times. So actually, standard drug doses are designed based on average adult requirements. They check the average adult requirement. With that, they will now design a dose for a particular drug. So what it means is that sometimes there are other factors you can consider before you conclude on a dose you can give to a particular patient. But this one you see, paracetamol of 500 milligram, 1 gram, 3 times daily for all the adults. It just was calculated on average. Okay, so the they are not actually universally suitable because you have to consider other things, put other things into consideration. There are many factors, both internal and external, that can influence how a drug works or how much of it that should be given. So these factors are categorized into 5 main groups. These factors are categorized into 5 main groups. We have physiological factors, we have pathological factors, we have genetic factors, environmental factors, and drug interactions. So we pick them one after the other. Let's start from physiological factors. Under physiological factors, we consider the age. The first physiological factors I want us to look at is age. So age of a patient have a lot to do with the dose and the effect of the drug on the patient. So the popular adult dose we know actually means those that we call adults are those that are between 18 to 60 years. Then this adult dose is for those people. Remember, this dose was calculated on average anyway. But infants and children, this group category of individuals are far more sensitive to most drugs. Why? The reason is because their enzyme system for drug metabolism is still immature. The enzyme systems for drug metabolism are still immature. For example, now, when it comes to glucuronidation actually develops fully or happens after 3 months. This metabolism takes place in the liver. So because the enzyme system is not yet strong, this glucuronidation will not be able to take place at before 3 months. So now tell me what will happen to such baby when you start loading the baby with particular dose of a drug, or even with a drug. It will become an issue for the baby. Then another issue for people of that age bracket is that there's what is called blood-brain barrier that separates the brain and the blood. Now, their blood-brain barrier is not fully developed at that tender age. So, what it means is that their central nervous system is at risk. So, you be careful about the drug you give them. In general, their kidney and the liver function are not fully efficient. So, have you not seen why they will tell you that the dose you give to children should be small because of these factors? So what, by implication, children under 12 years need only a fraction of the adult dose. Only a fraction of the what? Adult dose. Sorry, let me admit some people. Latecomers. You are doing pharmaceutical calculation now. I wouldn't want to go into that. The lecturer in charge of pharmaceutical calculation will teach you that about posology, about different rules, Clark's rule, how to use BSA, body surface area, to determine drug dose, and other rules involved in calculation of what? Doses. So you do that in your farm camp in posology. Okay, so now let's go deeply. Let's pick the one after the other. Newborns, that one's, you know, I just talked about children under 12. I just talked about infants and children. You know, newborns and infants are not the same thing. Newborns are the neonates. Newborns are the one that's newly born. So this one, they require even smaller doses than infants and children. Why? Because they have low gastric. One is that they have low gastric acid secretion. They have low gastric acid secretion. So what it means is that there will be increase in absorption of some drugs like ampicillin, and it's a problem for them to be loaded with ampicillin in their system for newborn. So that's why the dose are smaller, so that there will be no issues. Just as we see in infant and children, this one is not about their own self. It's not about not fully developed. This one, they are deficient in liver enzymes, specifically glucuronide transferase deficiency. They have this glucuronide transferase deficiency. This enzyme is lacking in the neonates. So when they're giving something like chloramphenicol at that age, they present with a syndrome known as gray baby syndrome. Gray baby syndrome. I want you to research on gray baby syndrome and tell me in our next class, so don't waste time. So that means neonates, you don't give them chloramphenicol because of that. Because the enzyme to take care of that chloramphenicol will not be there. So you are loading them with chloramphenicol, and it's a problem. Gray baby syndrome. They also have poor plasma protein binding. They have poor plasma protein binding. Remember the effect of plasma protein. It binds the drug, limits circulation and toxicity. So when they have poor plasma protein binding, it's a problem. Their kidney is immature. So their kidney function is also immature. At the same time, the blood-brain barrier is not there, not strong. So it's a problem too. Now, specifically for children, if you give them tetracycline, it can cause tooth discoloration. So this is effect. So you don't see that you don't even need to give them tetracycline for children. And also, if they are exposed to corticosteroid, they will experience growth retardation. And remember, antihistamines, antihistamines, you know what they do? They need to, most of them is to take care of what? Allergy. If you expose children to antihistamines, it can lead to hyperactivity. So you know what the dose you are giving them. Then for elderly patients, that is those that's 60 years and above, from 60 years and above, above 60 years. This one, just as what is obtainable in the children, in fact, the same thing is also obtainable to this category of individuals, because they have reached the peak of their life and they are going down. In fact, they've gone down the climax and they've gone down to the other end. So what it means is that their system, their organs, a lot of things in their system has gone down. So there's generally, in such individuals, there generally decreased body fats. Generally, there's decrease in body fat and even muscle mass. There is slower intestinal movement. Of course, you know the effect of intestinal movement in breakdown of drugs. You know the impact of fat and muscle mass when it comes to distribution. Then they also have reduced blood flow. It's not blood that will take the drug to where it should act. So if there's a decrease in blood flow, that means it will be sluggish. There will be accumulation somewhere. So you should be careful about the doses you are giving to such category of individuals. Of course, their liver function has gone down. The same thing with their kidney function. So you do dosage adjustment so as to suit their kidney and liver states to avoid accumulation and toxic effects. There is also reduced protein binding in elderly. I have described what protein binding is and the effect in circulation. There is also mental function decrease. There's a reduction in mental function. Their cognition will go down. So this has the effect with respect to things that has to do with drug and how they take their drugs. So these patients are high risk of, this category of patients are very high risk of adverse reaction. So what do you now do? In fact, it's even better to give them even oral forms are preferred for easier absorption. Remember, decrease in intestinal motility. For easier absorption, liquid dosage form is preferable. Of course, why is good for drug to leave the system? Even drug like diazepam, digoxin, under normal circumstances, they stay a longer time in the system, in their system, under normal circumstances. So now, when you now have in such people, they will not stay a longer time as expected. Of course, you know the effects. These things are potent drugs. So these are the effects of age when it comes to what the drug dose and effects. Let's look at the effect of sex. We are still discussing physiological effects. Let's look at the effect of sex. Let me admit somebody. Let's look at the effect of sex. When you mix, when I say sex, I mean gender. Whether it's a male or female, a man or men or women, that's what I mean by sex here. Not the act of intercourse. I mean the sex, the test of the male and female. Now, men and women respond differently to the same drug. It's shocking. Men and women can respond differently to the same drug due to their hormonal differences, hormonal influences. For men now, testosterone speeds up, makes drug metabolism faster. So that means males can metabolize faster because of what? Testosterone level. But if you come to females, they have more of estrogen. So estrogen can actually inhibit certain enzymes. Example, cholinesterase. Cholinesterase destroys acetylcholine. Now, if there is inhibition of cholinesterase, that means this acetylcholine-based drugs will now be highly, the women will be more sensitive to it because of the accumulation, because there will be more acetylcholine and its derivative in the system. So they are more sensitive. Women are more sensitive to what? Acetylcholine and its derivative. Now, for women, during menstruation, drugs such as salicylate and even strong laxatives should be avoided. Why? Because they may increase bleeding in women menstruating. Have you seen how sex can affect the dose and even effect of drug? Let's look at another physiological factor: pregnancy. Pregnancy actually, of course, you know that now once the woman is pregnant, a lot of things change, a lot of physiological changes occur in the body of the woman. And these physiological changes that occur in the body of the woman affect drug distribution and even elimination. Yes. Now, during pregnancy, there's an increase in total body water and even cardiac output. So this dilutes and accelerates drug circulation. So there is more drug circulation during pregnancy because of increased body water and cardiac output. Remember, it's no longer one person, two people are involved. It's even natural for them to be increase in circulation so that the baby will be able to get access to blood and the nutrients. Very important. You see how God designed everything. Now, in pregnancy, plasma albumin decreases. Because of decrease in plasma albumin, there is high tendency of there to be a lot of free drugs, active drug in circulation. So we watch that while dosing to avoid accumulation, excess in the system. Now, during pregnancy, there is a decrease, sorry, there is an increase in renal elimination. There's an increase in renal elimination. So drugs are cleared and eliminated faster during pregnancy. So what it means is that be careful about the dose of the particular drug you are giving, so that you'll be able to achieve your purpose of giving that drug. Now, during pregnancy, fat-soluble drugs easily cross the placenta. They easily cross the placenta, and they are even excreted more slowly. In fact, during pregnancy, avoid any uterine stimulant, anything that will stimulate uterus. Avoid it, because the baby is not safe. Avoid strong purgatives. Avoid teratogenic drugs. Teratogenic drugs are the drugs that will cause malformation on the baby. Teratogenic drugs that have teratogenic effect are the one that will cause what? Malformation on the baby. So avoid these classes of drugs. Have you now seen how pregnancy can influence the drug to be used, how to use it, the dose, and what have you? Even morphine. During labor, avoid morphine. Morphine should be avoided because it crosses the placenta. And morphine has this effect of respiratory depression. It reduces respiration. So it will affect the newborn respiration. So it's a problem too. So avoid morphine during pregnancy, during labor. Good. Now let's look at another physiological factor. I've mentioned this one before. Let me just say it again. Plasma protein binding. Plasma protein binding. Remember that plasma protein, the source of protein is from the food you eat. So plasma protein, if you eat well, if you are well nourished, you have enough protein in your system. So more plasma protein will be formed. But in malnutrition, in an individual that is malnourished, there is a drop in the level of the plasma proteins. And when this happens, there will be no enough plasma protein to bind drugs. And if there's no enough plasma protein to bind drugs, what will happen? What will happen? There will be a lot of free active drug in the circulation, and it's not good for the system. So, if you see a malnourished patient, you know how to go about the dose you are giving to the patient. Very important. Now, the next physiological factor is body weight. Body weight. Of course, you are familiar with this one. When you do your posology, you see how to calculate using body weight, how to calculate the dose. In BSA, use body weight and height. You using nomogram. These are topics you do in your Pharmacology, so I don't want to repeat it here. Then, there's rules that you just use only age. That's why you use body weight alone. So in all, dosage often depends on the what body weight. Please always use body weight. Don't just assume it's an adult. No, it's age. No, use body weight. Is very, very important. If possible, use height and body weight. Use nomogram if you can do the calculation. Use nomogram. So for a physiological man, the average body weight for dosing purposes is around 70 kg. So when an individual, a client, a patient is obese or underweight, then you have to do some dosage do calculation and do some dosage adjustment to get the actual dose the patient needs. So another factor, another physiological factor is lactation. Of course, you know what is lactation. Yes, breastfeeding. During lactation, during breastfeeding, certain drugs actually can be secreted through breast milk. So if you're a mother and you are breastfeeding a baby, there are some drugs can be excreted through the breast milk, and you start loading the baby's body system with unnecessary drugs, causing problem for the patient. In fact, some of these drugs for the infants or neonates, in fact, some of these drugs can even harm the neonates or the infants. Some of them can harm. Things like positives can be expressed in the what? Breast milk. You know what? You know when a positive enter the system of a baby, it will purge till the kingdom come and lose fluid. It's a problem. And apart from the positive, other effect in the system is problem. Penicillin can be expressed in breast milk. Chloramphenicol that can cause gray baby syndrome can be expressed even at oral anticoagulants. Can be expressed. So it's a problem. So be careful about these drugs when you are what? Breastfeeding a baby. There are a lot of them. If you get your MDEX, go to the back of it. If you get your MDEX, go to the back of MDEX. You see a lot of drugs that cannot be used in particular situations. They are contradicted in pregnancy. Let me admit some. Okay, no. Wait, Celine, do you have a question? Okay, I assume that you raised your hand before. Okay, let's continue. So, another physiological factor is food. Food. We write it under physiological. Food can actually, of course, you know this one now. We have discussed that one sometime in the past. Food can alter drug absorption. Food can alter drug absorption. In fact, generally, drugs are absorbed faster on an empty stomach. Generally, even though there are some drugs that may be or something like some artemisinin-based combination, some artemisinin-based combination, presence of oil food can help the absorption anyway. Yes. Now, but generally, food help in what? Generally, when in an empty stomach, food is absorbed faster. But due to the fact of some effect of drug like irritation, so you are advised to take it after meal, but at least give a space so that they give space, not just take it together like that. Just after meal, you can take it. In fact, some drug like anti-motion drug, all these and the anti-motility drug, even antiemetics work better on an empty stomach. Example of antiemetic, you know now, you are warm medicine, the one you call warm medicine, like your levamisole, like your pyrantel palmoid, like your albendazole, like your mebendazole, all these ones, they work better on an empty stomach. That's why they tell you don't eat, chew it on an empty stomach because they are more effective. Exactly, they work better on an empty stomach. So I mean, now see how food can influence the dose and even the effect of drug in the system. If you take artemether lumefantrine or artemisinin-based combination for malaria, and you go and take anything that contains antioxidants like vitamin C and some other vitamins, they will not allow the to work. We should talk about it in what interaction. Now, let's look at another factor, another physiological factor, allergy. Let's look at allergy. Allergy. What is drug allergy? Drug allergy is just an abnormal immune response. It's an abnormal immune response. That's antigen antibody. It's an antigen antibody reaction. It's an abnormal immune response that releases histamine specifically, and it can cause rashes, urticaria. It can even cause anaphylactic shock. Specifically with penicillin, it can cause anaphylactic shock. So the anaphylactic shock is more serious. It's even deadly than ordinary rash and itching. So you have to know your history before you take any drug. So if you know there are some people that react to chloroquine, but they don't react to. There are some that don't react to it. Some if they take there are a lot of reactions. So you should know your allergy history before you take any drug. In fact, if you don't know, it's always good when you are taking a drug you have not used before, you take a small test dose first, especially when it comes to other route of administration. Of course, when you are administering somebody a drug for the first time, it's always good to keep by your side emergency drugs in case of anything, so that you can easily help the person. So another factor is drug dependence and addiction. Drug dependence and addiction. You have done this one in your AUM 122. So I'm not going into it. I'm not talking too much on that. You did drug dependence and addiction in your AUM 122. So let me just say one two things about dependence. Is a state where normal functioning becomes impossible without a particular drug. You have become so much that this drug is dependent on that drug that normal physiological function cannot take place unless you take that drug. You are not understanding anything again unless you take that drug. Features of it: we have temporary pleasure. Once you take it, euphoria. Euphoria. Oh, pleasure, temporary. Tolerance is a sign of drug dependence and addiction. Tolerance. What is tolerance? Intolerance. To achieve the same effect, you will need higher doses. Over time, you will need higher doses of the same drug to achieve the same effect you achieved in the past. It's a sign of drug dependence and addiction. Even psychological dependence. This one you'll be craving, even though there's no physical harm yet, but you are craving for it. Then physical dependence. This one, if you want to withdraw, wahala. Withdrawal symptoms will now come up. We have what is called withdrawal symptom. If you want to stop a particular drug that you are addicted to. So withdrawal symptom is a problem. These are the things you are discussing and you want to do, so I won't go into that. Now let's go into pathological factors. We are done with physiological factors. Let me admit some people. Okay, let's continue. When is this class ending? So, when do you want me to end this class?
Yes, sir.
What are your
5
So when
o'clock, sir.
5, okay,
Yes.
see what will happen.
Yeah.
If we get to 4:30,
Yes, sir.
we stop discourse, then we switch over to BDP. Is that
All
clear?
right.
So that's what we do. So at least even if it's 30, even if it's 30 minutes, we'll discuss something there, okay?
All right, sir.
All right. Okay, let's continue. So, so in pathological factors, this one talks about, anytime you hear pathology, it's talking about disease condition. Disease what? Condition. Anytime you hear pathology, it talks about what? Disease condition. Pathological factors like when in liver situation, liver disease, yeah, if the patient has liver issues, there will be decrease in metabolism. I think I've talked about that, and prolonged effect. So what it means is that what it means is that the drug will not be metabolized. It will just be there. The effect will be there for a long time, and it's not good for the system. The time it ready to do its work and go, it will still be there, continue doing the work because it cannot be metabolized. Then another situation is what? Renal disease. In renal disease, there is also there is reduced excretion, elimination. And if drug is not eliminated from the body, there will be what? Toxicity. They will accumulate in the body and it's risky. Another situation is malnutrition. I think I mentioned it. Malnutrition. So there is, if there's if in malnutrition, there's a reduced plasma proteins and more free drug, more toxicity, more issues in the system. Are we together? Are we together? Now, let's look at genetic factors. Let's look at genetic what? Factors. Now, let me say one or two things about liver disease. Under liver disease now, some drugs that when you have reduced plasma binding, plasma protein, you see more free drug, things like warfarin and theophylline. When you have impaired blood flow, you see morphine, propranolol, their clearance will become an issue. Not only these people, these drugs, so other drugs in question. Are we together? I believe we are. So let's look at the genetic factors. Let's look at genetic factors. We have genetic factors. Genetic factors not just about other environmental or physiological or pathological. There is also there is what is called genetic genetic disposition. The genetic disposition of a particular individual has a lot to do with the effect of drugs in the body, in the how the body takes care of a drug. So these factors are inherited. They are inherited traits that affect enzyme activity and even receptor sensitivity. We have idiosyncrasy. Some people are idiosyncratic to a particular drug. In fact, this idiosyncrasy is just an abnormal, unpredictable drug response on first exposure. You never knew that this person, on first exposure to a drug, reaction, abnormal reaction, and unpredictable. Then we also have what is called genetic polymorphism. In genetic polymorphism now, there's what is called, there are individuals categorized as how we are the fast acetylators. we have the slow acetylators. This one now, because of their genetic makeup, acetylation is part of metabolism in the liver. They can easily metabolize a lot of drugs. Fast acetylators. So this one, they have their genetic disposition allow them to even metabolize acetylate as a metabolic pathway different drugs so fast. Especially something like isoniazid. There are some individuals that can, acetylate and metabolize it faster than the other. So what I mean that if you now load somebody that is not a fast acetylator with such drug, the effect on the system will be a problem. Then for those that you are giving that are fast acetylators, you be careful about the dose you are giving them, so that at least you'll be able to have enough to be able to take care of what you want to treat. Then another group of individuals, another group I want to talk about is under this genetic polymorphism. We have the people that are pseudocholinesterase deficient. Not only isoniazid, though, sulfonamides are also involved in this acetylation. There are people that are pseudocholinesterase deficient. This one and these people, if they get exposed to succinylcholine for a long time, it can lead to what? Paralysis, because they don't have what it takes to destroy, metabolize the what? Succinylcholine. By the time you do skeletal muscle stimulants and other things, we discuss this. Are we together? Now, there are a lot of them. When you get your material, you see them. I don't want us to be wasting much time on this. Yes. There are also what is called malignant hyperthermia. This one is triggered by succinylcholine due to calcium regulation defects. All these things, you understand it better when we go to skeletal muscle stimulants. Let's look at environmental factors. There are environmental factors that affect, determine, modify drug dose and effect. Things like a route of drug administration. Remember we discussed route of drug administration. Route of drug administration has effect too, because the route you use to administer a particular drug would determine how the absorption will look like and the corresponding effects. Remember what we said about intravenous as against oral and other routes. Which one is faster and which one will have higher bioavailability? Please recall all those ones. You understand what we mean, how route of drug administration affects, modify the dose. The same time of administration matters a lot. There are some drugs that work better at night. Things like hypnotics. Just take it and go and rest. That's why you see something, they'll say, please, apart from, yes, we know that maybe if you are driving, you can be sleeping if you take some drugs. That's why it's okay, because of that now, take it so time in the night. Because if somebody takes it in the day and is free somehow, the person will not want to take that drug again. It will affect compliance. They have no drug at all, let alone absorption. Then climate also affect drug. The climate, the race, the preparation also affects how those are modified, the doses. Basically, metabolism is slower in the hot and humid areas. Yes. So Purgatives act better in summer. Diuretics in winter. So this climate also affects race. Yes, some certain races respond differently to drugs. For example, now if you give castor oil to Chinese, it's ineffective because of the genetic makeup of their race. There are many factors under these environmental factors. Of course, now, if a drug is outdated, some drugs you don't, even though yes, some people say this drug is outdated, and because of that, I can still use it. There are some that if you try it, you have problem. Go and try it with tetracyclines. When tetracyclines get to their become outdated, please tell them we don't say it has more extra 3 months. Let me use it, throw it away. Unless you want to enter into trouble. Okay? Now, of course, now you know about GIT acidity now, how the acidity of the GIT affect absorption. We talked about it before, so it's not a new thing. Even the disease condition of the GIT, how disease condition will affect the drugs. We talk about it, so we are not going to be repeating ourselves over and over again. Even the form and the form of the drug, we talked about it before, the dosage form. So let's not waste our time there. Then, hypersusceptibility. Yes, it's a fact, it's a problem too. Some individuals usually are sensitive to normal dose of a drug. Normal dose, everybody is sensitive to. I'm just looking at generally about the factors that can affect the modification of those. We discussed tolerance. Tolerance is what? Repeated reduction in the response, even when the same dose is administered. Something like morphine. If you get used to morphine, I'm sorry for you. If you get addicted to alcohol, sorry is your name. You want to drink more. Tolerance is what is happening to you. In fact, there's also cross tolerance. Cross tolerance is that this person will start having the same effect, tolerance to even drugs that are similar to the drug that they have that is tolerant to. Something like some people would not start having something like petidine and morphine are similar in a way. You see the person even becoming tolerant to petidine because petidine and morphine are related. All right, so let's look at another factor, drug interactions. Let's look at drug interactions. Let's see how drug interaction affects drug dosing. The dose modification. So the drug interaction I want us to look at, let's look at synergism. Synergism. What is synergism? In fact, drug can act if you take two drugs. Sorry, we are specifically talking about drug interaction though, because we talked about food-drug interaction before when we talk about food in physiological factors. This drug interaction, I want to focus on drug interactions. So when two drugs are used together, there can be what? Interaction. Their action can be enhanced. One can enhance the action of the other one, or there can be what? Inhibition of each other's effects. So synergism occurs when two drugs are work together to produce a greater effect. That means they have synergistic effects. Examples of synergism is potentiation. Potentiation is an example of synergism. What happens in potentiation? If you combine the two drugs, if the effect of the two drugs when combined is greater than the sum of the individual effect of the drugs, each of these drugs, then what happens is potentiation. This happens when you use levodopa and carbidopa together. We also have the one we call additive effect. It's an example of what? It's a type of synergism. This one occurs when the combined effects of the drugs you brought together is the same thing with the sum of the individual effects of the drugs. This situation is called additive effect. This happens when you combine aspirin and paracetamol. In fact, some combination you see aspirin and paracetamol, the effect it will have is what? Additive type of synergism. Another type of interaction I want us to look at is antagonism. Antagonism, of course, when one drug reduces or cancels the effect of the other drug, they antagonize each other. We have chemical antagonism. We have pharmacological antagonism. We have physiological antagonism. For chemical antagonism, this one occurs by direct chemical reaction. Direct chemical reaction. You see that one in antacid. When you take antacid will directly react with the acid in the stomach to carry out what is called neutralization reaction, to neutralize the acid. So this one is a chemical antagonism. That's what we employ when we use antacid to neutralize the acid in the stomach. Then we have pharmacological antagonism. Under pharmacological antagonism, we have competitive. We have competitive pharmacological antagonism and non-competitive pharmacological antagonism. For competitive pharmacological antagonism, competitive, this one, both drugs, they compete for the same receptor. A drug A normal will bind to a receptor to elicit its effects. But the antagonistic one will compete with it so that it doesn't bind with that receptor. That means both of them are complementary to the receptor. Both of them are complementary to the receptor. Each of them have complementary faces where they can bind to the receptor. So they fight for the same receptor. So this is what we call what? Competitive antagonism. Example is acetylcholine versus atropine. There are many of them. You can find out more of them. Acetylcholine plus versus atropine. They pharmacologically compete for the same what? Receptor. They antagonize each other. Now, let's look at non-competitive. Non-competitive, they don't, this one, the antagonist itself, the antagonist does not compete with any receptor. The antagonist is a bad guy. It doesn't even send you self. It will go and destroy that receptor. It will go and inactivate the receptor so that the other one does not bind. The agonist does not bind. Will not see where to bind. And if it does not bind, its effect, it will not exert its effect. So this one is not about competing. No, this one it will go and inactivate the receptor. To mess up the receptor. Since I cannot, because that one the non-competitive does not actually fit in. So it's only that so far I don't fit in, you will not fit in, it will destroy the receptor so that the agonist does not bind. So this one, inactivate it has no business with no matter the concentration of the agonist, it doesn't concern him. It will exert effect. But in competitive, concentration of the agonist can actually have effects or whether it can succeed. But for non-competitive, it has no business with the concentration of the agonist. Example is seen in phenoxybenzamine and the adrenaline. Phenoxybenzamine and what? Adrenaline. There are many other examples. I don't want this lecture to be too long. I'm hitting the main points. So that when you now study more, you now appreciate the foundation I've laid. So what is there any clinical relevance of this interaction? Be it synergism or antagonism. Okay, sorry, I've not discussed physiological antagonism, please. Physiological antagonism. For physiological antagonism, the two of them are not acting on the same receptor. They have not been able to the same receptor. This one act on another receptor. This one act on another receptor. But the effect of this one in this receptor affects. This one is acting on another receptor, but it's affecting the effect of the other one. The effect of this one is countering the effect of the other one, even though they're not acting on the same receptor. So such is called physiological what? Antagonism. Example is seen in adrenaline and histamine in asthma. Adrenaline, they're not acting on the same thing, but their effects are opposite, even though they're acting on different receptors. So what is the clinical relevance of this interaction? You can exploit this interaction for the good of your patient. Antagonism can be used to treat overdose. Yes. If you know that, like now, if you take morphine, high dose, overdose, you can actually use naloxone. So morphine and naloxone may counter the effect of morphine. So this is how you can exploit it for the good of your client or your patient. Depending, there are many of them. Of course, if you have knowledge of the effect of drugs, you know how to avoid using the two of them together. The commonest one you see around is ciprofloxacin and the iron supplement, iron hematinic containing iron. Iron will not allow ciprofloxacin to work. So if this knowledge will not allow you not want to put them together, use them together. It's always advised, after treatment, you can commence your what is it called? The hematinic, iron-based hematinic. So in conclusion, the action and safety of a drug depends on numerous personal, genetic, environmental, and pathological factors. By personal, I'm talking about physiological factors, not personal, please. So if you understand how these factors influence the dose and effect of drug, it will help clinicians, even you, to know the dose, how to adjust the dose. And at the end, the idea is to do what? Achieve the best therapeutic effect while minimizing toxicity. You know, one thing unique about pharmacy is that you achieve their therapeutic effects at the minimal toxicity. That's why you know that you have actually succeeded in what you are doing. But if you achieve therapeutic effect with very high toxicity, it's a problem. You not achieve anything. In fact, you compounded the patient's problem. So that's where the lecture will end for AUM. It's exactly 4:30. Any question? Any question? Any question? Okay, silence means that there's no question. All right, so we'll stop it for today for AUM. Please hold on because we are continuing with what is it called? Hold on, we are continuing with BDP, okay?